Now, the last video was a little short, and it's all because another common overdose or toxin is alcohol dependency. And dependency in and of itself is something that we need to talk about. But let's finish with ETOH ingestion. So, based on the amount, the quantity, and timing, and what it was taken with, and anything else, those questions we need to ask and find out. Now, this can cause to stupor, coma, aspiration, and even death. So, we want to make sure we do a good history, a good exam, and then evaluate your patients for such. Now, in any of these medications that we talked about, even the illicit substances, they will create some type of dependency. And dependency is more like clarified as that they need to have it physiologically. It's not necessarily psychologically, but physiologically they feel like the body doesn't respond to what they normally would without it. They're going to postpone doing activities if they can't get it. So rather than going to an event, they would rather just stay back because it's prohibited to consume such substance. They may end up becoming more withdrawn from society. This will cause issues with potentially showing up to work, being responsible for their activities of daily living. And then there's this strong need for it, like there's a craving or an urgency to have it. Now with dependency comes that addiction. So now the body becomes tolerant for that chemical, and so you need more and more and more and more of that chemical to create the same euphoric or whatever behavioral effects that it then exhibits on the person that's taking it. But they require more and more as they build up this dependence, and everything goes around this dependence. Now, should we go ahead and automatically, we execute and deploy some countermeasure to eradicate this substance? We may turn them into this acute withdrawal syndrome. And when we look at acute withdrawal syndrome, we're looking at strange, bizarre behavior, arrhythmias, respiratory issues, multiple complaints of feeling uneasy, body aches, nausea, vomiting, and we can even throw them back into seizures, convulsions, stuff that we can't control, and then we're throwing more meds at them. So in the pre-hospital setting, it's safer to play on the safer side, manage and support their airway, breathing, circulation, than try to throw them into acute withdrawal. Less chance of this happening with alcoholics, as there isn't an antidote that we give in the field. Less chance of that with benzodiazepines or Valiums, Versed, Prazolam, anxiolytics, because we don't carry an antidote. The antidote again would be Ramazicon, Flamazanil, but we can do this with people that are on narcotics or opiates, and sometimes they are in the middle of taking medications to curb their dependency on it, and these are patients that are on Suboxone or Methadone, and these patients are trying to wean themselves off of narcotics. So we really need to be careful about the withdrawal when you give them the antidote. What is the antidote for opiates? Naloxone or Narcan. When you start giving them these, this will cause this immediate withdrawal, and so we want to really be careful about doing so. We're going to start wrapping up the end of toxicology. I hope this really helped you. Again, some of the review things for all the modules and videos that we went over. So first of all, we want to be able to understand that there is signs and symptoms that associate themselves with the toxic substance. The toxic substance is something that being taken into the body and once entered into the bloodstream can overwhelm it, causing toxic effects. These toxic effects then present themselves in the toxidrome, the signs and symptoms. Based on that, then we can identify what might be causing a person's symptoms, i.e., if they took a bunch of opiate narcotics. And then we see pinpoint pupils, respiratory depression, CNS depression, cardiovascular depression, so hypotension, altered mental status, pinpoint pupils, and respiratory depression or arrest. The only caveat with this antidote that we would give is that we want to be careful not to cause them to go into immediate withdrawal, or that when they come out, that they become violent, aggravated, agitated, may cause harm to themselves or others or ourselves. And again, the antidote for this is naloxone or Narcan. So follow your local protocols for that. So again, some of our drugs, and we're not going to go over the drug profile, we're not going to go over the syndrome, we're just going over the antidotes. So Tylenol, acetylcysteine. Narcotics, naloxone. Benzos, we're looking at romazicon, flumazenil. Nitrates, that's not the nitroglycerin, but we're looking at fertilizers, we're looking at methylene blue. Organophosphates, that is your cholinergic, your sludgeum, so we're going to give them an anticholinergic, atropine, and a binder to PAM chloride. Some other drugs that we didn't really cover, but is helpful. I'll come back to them. Just kind of lost my train of thought. Let's finish up with antidepressives, anti-epileptics. If available, we might give them something that binds the drug, so that once it is bound, it can be excreted, and then we can alkaline the urine, and then we alkaline the urine, give it bicarbonate. And the other cases, we are also trying to be supportive of either respiratory, CNS, or cardiovascular for arrhythmias. Amphetamines, crystal meth, we might think about giving them a kind of benzodiazepine to control or blunt the sympathetic response. That's not necessarily in a local protocol, and then we don't want to add to that and polypharm. So communicate and then figure out what we might want to do. And then lastly, remember our severe questions as far as what was taken, how much was taken, when it was taken, what it was taken with, and was there anything else that they took with it. Some hodgepodge I kind of remembered. So for heparin overdose, heparin, that's something that they'd give in the hospital. We give protamine sulfate. And well, good luck in studying, and keep up the good work.